Dr. Eva Galvez is a family physician at Virginia Garcia Memorial Health Center in Hillsborough. She is a native Oregonian, the daughter of immigrants, and a graduate of Oregon State University. Her medical degree is from the University of Washington, and she completed her residency at Swedish Family Medicine Residency in Seattle. Dr. Galvez's leadership in this time is exemplary. She was awarded this year with the Alumni Fellows Award by Oregon State in recognition of that leadership. Dr. Galvez is a trusted advocate in Oregon for vulnerable populations, especially those most at risk in the pandemic that is currently exploding across the country. She's been interviewed in numerous media outlets about her experience working with migrant workers during this difficult time. She will talk with us today on the disproportionate impact of COVID-19 on Latino communities and how physicians can be helpful in advancing health equity in the community. So with that, I will welcome Dr. Eva Galvez. Thank you.
Thank you so much, Betsy, for that introduction. First of all, I just want to thank you again, Betsy, for the invitation to speak about this topic today. I want to thank the Oregon Academy of Family Physicians for inviting me to be here. For those of you that are at home today and that you made time to be here with me, thank you so much. Before I get started, I wanted just to say a couple of words. I want to say that I realize that there's a lot of expertise in the community about social determinants of health and health equity. And what I'm here to do today is really give you a perspective from a family physician, somebody who is on the front lines, who's taking care of patients every day, like many of you are. And so, you know, these are much of what I'm talking about today are the way I see things, some of the lessons that I've learned. And I hope that you will find this valuable in your own journey on trying to bring health equity to the community that you serve. So first challenge of the day here is I need to share my screen. So bear with me here just a bit.
You are muted. Dr. Galvez, I'm going to ask you, I'm going to send you an ask to unmute request.
Unmute.
There you
go. Can you hear me now?
Yes, okay. And it looks like you're sharing your screen.
Okay, better? We're okay?
So.
Okay, thank you so much. So let's talk, I just want to go over some of the objectives today. So today what I really want to do is I really want to take a step back and really just talk a little bit about the factors that shape health. I also want us to, and I'm going to be using once again the Latino community as an example of this. I want to talk about social determinants of health, and I want to show us how they drive health outcomes, and to also kind of have us understand that addressing these social determinants of health is really essential to reducing health disparities. And for the last third of the presentation, what I really want to do is I really want to bring it back to physicians and talk about ways that we can be active participants in reducing health disparities and advancing health equity. So I would like to start first by talking to you about a patient of mine. So I want to present to you Luis. Luis is a 68-year-old seasonal farm worker from Mexico. And when I first met Luis, he was in his mid-50s and he was healthy and strong, and he had no major health problems at the time. But about 2 years after I met him, Luis was diagnosed with type 2 diabetes. And over the next few years, my healthcare team at Virginia Garcia Clinic really worked hard to get Luis's diabetes under control. We really helped him by ensuring that he had access to affordable medications. We provided him with resources such as behavioral health counselors so that he could achieve his lifestyle goals. We also talked a lot about nutrition. So we spent a lot of time with Luis and trying to get his diabetes better controlled. But over time, his diabetes did get worse. His A1C did begin to rise. And 2 years ago, he ended up with an amputation of his right middle toe. Despite this amputation, Luis never missed a day of work. And over the years, I had the privilege of getting to know Luis really well. And he told me that he had grandchildren and children living in Mexico. And he was building a home in Mexico with the money that he was earning here in the States. And his goal was to earn enough money so that he could complete his home and move back with his family. The last time I saw Luis, he showed me a picture of his entire family standing in front of his almost completed home. And he told me with so much excitement that he thought with just about another year of work that he would have enough money to finish building his home in Mexico. And with that money he had left over, he planned to purchase a taxi so that he could live in the family that he had built, while at the same time supporting his family. Last spring in April, as our COVID-19 pandemic began to unfold, I received a call from Luis that he was suffering from fevers and body aches. And I told him that his symptoms were concerning for COVID and that he should come in for testing. However, Luis declined to come in at the time, and that following day, he called again stating that his symptoms were getting worse. And at that point, I told him that he needed to go to the emergency room for care. But he was worried about going to the emergency room because of the cost, and he insisted on coming into our drive-through testing center in the afternoon. And so we reluctantly placed him on that schedule. But as I waited for Luis outside at our COVID-19 testing station, Luis never showed up. A few hours later, I found out that he had arrived to the hospital in a respiratory failure. He was intubated on arrival, and then he died weeks later alone. So my question to all of us that are listening today is, what did Luis die from? The obvious answer is that he died from COVID-19 complications. I don't think any of us would argue this. But I'd like us to consider what were the conditions that led to Luis's premature death. Because when I'm here to illustrate to you today that Luis's premature death from COVID-19 is actually the result of the conditions in which he was born, raised, and lived. You see, Luis was born into poverty. This forced him to immigrate to a country to find work in order to support his family. And because of his limited English skills and limited education, the only job that Luis could find was as a low-wage seasonal farm worker. And even before COVID-19, agricultural workers were very vulnerable. They are exposed to highly hazardous conditions due to pesticide exposure, extreme weather conditions, such as heat and poor air quality. And often exacerbating these conditions are the lack of workplace regulation standards. But then when the pandemic hit, Luis became even more vulnerable. He was deemed as part of a group of workers that were now considered essential. And in other words, he had to leave his home. He did not have the luxury to work from home. In these essential jobs, agriculture, food processors, caregivers, often what you see is people working in close conditions, standing side by side, working in crews, and unfortunately, often without PPE. I've had patients even in July tell me that they have not been given the PPE. I had a diabetic patient that was riding in a van with 8 other berry pickers in July. She was not given PPE. And then if workers like Luis do fall sick, most don't qualify for sick leave benefits. Often, they're forced to choose their economic survival over their own health. And then complicating matters, Luis was paid very low wages. So in order to afford rent, he was forced to live in an apartment with a family of 6, conditions that we know contribute to the spread of a virus like COVID-19. And let's remember that even though Luis had access to the Virginia Garcia healthcare team, he did not have health insurance, even though he was considered an essential worker. This forced him to delay getting care when his symptoms from COVID began to worsen. And then finally, let's not forget that many people like Luis face high rates of discrimination and exploitation in their workplaces and in their community. This leads to high rates of anxiety, depression, stress, conditions that we now understand are linked directly to poor health. But I want to pivot away from Luis now, and I want to bring it back to us. Because I can bet that most of you in the audience today have patients that are very similar to Luis. Maybe they're not farm workers, but they probably have and live in undesirable conditions. And we see them dying, perhaps not a sudden death like COVID, but a slow death from uncontrolled diabetes, chronic kidney disease, drug and alcohol addiction. And if we go back far enough into that person's life, we can see how these conditions begin to take shape in childhood and sometimes even at birth. But why should physicians, healthcare providers like you and I, why should we be having a conversation about this? And why should it matter so much to us? Well, because it turns out that it's these conditions that I've just discussed, these social conditions, or what we refer to as the social determinants of health, are the primary driver of health outcomes in the patients that we take care of. But in order for us to understand this, I want to take a step back and I want to talk about what determines health, right? Because it turns out that our health is made up of many different factors: our individual behaviors, our genetics, our social circumstances, environmental factors, and of course, healthcare. But interestingly enough, healthcare, even though we spend a lot of time talking about healthcare when we talk about health, health is really only about 10% of what accounts for our health, right? And it turns out that it's actually these social determinants of health that are driving the health outcomes, right? So it's a community and social context, access to food, access to education, our neighborhood and our physical environment, and our economic stability. And healthcare systems, which is where you and I are, is important and is a part of what makes up health, but it's only a small piece of what drives health outcomes. But the other thing that's interesting that we've done, I wanted to flip back to the slide that I just showed you, is that recently there's been a shift in medicine to really focus on changing our patients' behaviors, right? And this makes sense because it's about 40% of what we do, of what determines a person's health. But I would like to argue that even our behaviors are pre-shaped by the conditions around us. And to illustrate this to you, I'm going to give you an example. So I exercise because I know that it's good for me. But this decision to go out and to exercise is facilitated for me because I can afford a gym membership. So I have the economic stability to afford a gym membership. And I also have a car to get me to the gym, and I can afford the gas. And even if I can't get to the gym, I can still exercise in my neighborhood, because it turns out that in my neighborhood, not only is it safe, and not only do I have clean air to breathe, I also have really nice walking trails, right? So, and I would like to point out, though, that these conditions that I've just laid out, which we often refer to as, I've heard people refer to them as the traditional social determinants of health, right? Housing, neighborhood, transportation. It actually turns out that these traditional social determinants of health are actually being shaped by stronger forces, right? By economics, race, politics, power. And so it's these things like economics and power and race that actually determine how we distribute resources in communities, and therefore drives these social determinants of health. But I don't want to leave you with the impression today that I'm dismissing the importance of personal choice and responsibility, or even the importance of our work in trying to change behaviors. But simply what I want to point out, that focusing only on this is not enough to bring health to a community, right? We need to begin to recognize that health is more than just an individual responsibility, and more than just a responsibility of a healthcare team and their patients, right? We need to begin to think about this as being the responsibility of an entire community. So it's really up to the community to ensure that there are the right conditions in place so that people can make healthy choices. And I really think this is an important piece of my message today, because I think that when we can begin to acknowledge as a society that much of what is driving health is really beyond the control of an individual, this is really when we can begin to take that first step in advancing health equity. And I think for physicians, many of us understand this at a gut level, that there's social conditions that are impacting our patients' health. But sometimes what happens, because our training is really geared at, it gives us this notion that somehow we are responsible solely for our patients' health. And I would say that this is a false notion, because we cannot be the only ones responsible for health. Because what's really driving illnesses, we know now, is the things that are happening beyond the walls of healthcare. So just to kind of summarize some of the points that I've made up until now, I want us to really drive home the point that social conditions do matter when we're talking about health, right? And that if we really are wanting, and that they drive health disparities, and that we're really interested in reducing health disparities, which is what we need to bring health equity, we really need to begin to look at these social conditions and address them as part of a framework to bring solutions. So, so I want to shift now to talk a little bit more about physicians and our role and where we go from here. But I think it's important for me to emphasize is that these conditions that I've just laid out are really complex, they're deep, they're systemic. And so I don't think that just the healthcare field has the answers. And honestly, I don't think any sector has the answer. This really is going to take a multidisciplinary approach where we're reaching across disciplines, right? In order to really address those root causes. So sometimes the way I think about this is having different layers, right? And within these layers, there's different areas that we can work in, right? So there's the individual biology, there's the community networks, there's the living and the working conditions, and then of course there's the policy and the socioeconomics and the larger environment. But as physicians, when I look at this, I think, well, where do we fit in, right? our training is very specific, right? To take care of people that are sick. So where do we fit in? And so over the next few minutes, what I want to touch on is that I believe that there is a lot that we can do as physicians to address these inequities that I've laid out. And I think it's going to take a couple of things, though. I think the first is that we will need to think about building new skills as physicians, right? But the other thing is we need to really begin to think about the work that we do on a day-to-day basis a bit differently as well. So I want to pivot now to expand on these two ideas that I've just talked about. And the first one is really thinking about ourselves as advocates, okay? So physician advocacy, right? And so when we think about advocacy, I always say advocacy is really just being a representative who speaks in support of a community or of a person, right? And advocacy encompasses different levels, right? There's the individual level, there's advocacy that can happen at a community level, and then there's advocacy that can happen at a systemic level, right? And I would say that physicians, we're actually really good at being advocates at this individual level. We develop these skills really early on, probably within our third or fourth year of medical school, right? We learn that that when we're taking care of patients, for example, and we're discharging our patients from the hospital, we make sure that they have transportation to their specialist appointments. We ensure that if they're homeless, that they have a safe place to go after discharge. And even now, right, if we prescribe a medication for our patient, we ensure that they can afford it. And if they can't, we talk to people so that the patient can get the medication, or we call the specialist to say, hey, listen, this treatment plan isn't going to work. So I think that we are doing advocacy already, but it's at a very, very, it's an individual level, right? And then there is advocacy, though, that can happen at more of a community level, right? And then this is when we really work to improve the conditions, not only of our individual patients, but of the community that we serve, right? So for example, that could be at Virginia Garcia, our work to bring, to partner with Oregon Food Bank to take food to patients who are in quarantine and isolation, right? Or it can be working to help bring parks to low-income neighborhoods, right? Or just simply programs that promote community relationships and health, community gardens, that kind of thing. And then there's that policy level, right? And that's the systems level. And that's really when we work to change policies or to create policies that can promote health. And so this, examples would be, talking about the pandemic, right, and how it's impacting the Latino community. This would be advocating for sick leave benefits for our essential workers, or advocating for healthcare for all of our essential workers. These are really, we're advocating at a level that is going to impact a large amount of people. And advocacy at a systems level really does take a lot of time, but it's worth it because it does impact a lot of people. But coming back to us, how can we do any of this, right? And so I would say that, like I said earlier, individual level, we're good at this. I think the community and systemic level, we still need some practice, right? And this is not our fault. Our training, most of us who have gone through a traditional medical school training don't typically have these skills, right? To begin to work on policy, right? But I would say that one of the things that if we really are interested in working in some policy and at these higher levels, we really need a good foundation at the individual level, right? We really need to understand the barriers that our patients face, right? And then the other thing we need to do is we really need to get to know our community. And so it requires moving out of our comfort zone, right? Building relationships with community members, people who are working in community-based organizations who are working towards the same goals. It does take time, but I think that it's possible. But I want to point out that one of the pitfalls, I think, as physicians is that oftentimes when we think of advocacy, we think of advocacy on the systems level, right? And so then we just think, oh, we can't do anything. This is just too much. And although I do want to emphasize that absolutely this work at a policy level is extremely important. Physicians can be very effective at different levels, right? And also, I think we just need to be patient with ourselves because our training isn't really geared for this kind of work. And so I would say that this is something that we want to do. We really need to begin to develop those relationships and be patient with ourselves as we can grow into these roles. But with that said, I still think that there are things that we can begin to do as a profession to begin to build a foundation for physicians that are comfortable and willing to work in advocacy at these higher levels. And so, how can we foster these skills, right? So the way I see it is we need to sow the seeds of advocacy and health equity early. So starting in that first year of medical school, right? So in that first year, as our medical students are learning the pathophysiology, that they're also starting to become familiar with the social determinants of health. And that by their third year, when students are learning how to take a history, that they're not only thinking about family history and tobacco use, but they're also thinking about where a person works or where a person lives, right? And so that by fourth year, our students are really experts in actually interpreting the impact of these social determinants of health on their patients. And so that it becomes part of their treatment plan, right? And then in residency, I think that we can build on these skills by providing opportunities to learn more about the specific community that we serve. For example, taking residents to where their patients work. Like my good friend Dr. Gobo in Hood River, he took his residents to an orchard so that they could see the working conditions of their patients, right? And I think that when we begin to step out of our comfort zone, not only can it deepen that relationship with our patients, it deepens the understanding of the barriers, but it also can provide us some really good insight about where we can focus these advocacy efforts, right? But, we also need to think about how we can begin to provide opportunities to actually engage in advocacy work, right? And this might look differently for different communities, but I think our faculty can be valuable resources and they can role model this behavior. For example, we can have faculty who can develop skills to write letters to our representatives, right? Or we can take residents when we give oral testimony on a healthcare bill. Because again, I think the way I think about advocacy in residency is a lot like procedures, right? So we're not always experts on procedures that we want to do when we leave residency. But we know that if we're exposed to those procedures early on and we practice a little bit during residency, that we're more likely to do them when we're out. And so I think advocacy is very similar. If we begin to have this exposure early on, we become comfortable with it and it becomes a natural part of what we do as physicians. Now, I want to shift now to talk a little bit though about the physician workforce, because I think many sectors right now are starting to look inward and really looking about how they can have more diversity in their workforce. And I think that as a medical field, we too need to begin to find ways to have a more diverse ways. For one, we know that this can translate into better care for our patients, but also we know that people who come from diverse backgrounds, whether it's diverse cultural and ethnic backgrounds, diverse lifestyles, we know that they bring different points of view and different perspectives. And this too can be really helpful in tackling some of these issues that I've laid out. But, a diverse workforce doesn't just happen, right? And for us, we need to begin to think about recruiting or bringing that diversity in to our medical schools, right? So we need to look at how we're recruiting students and where we're recruiting students, right? And so, historically, medical schools have put a lot of emphasis on science background and on grades, and absolutely this is important. But I ask us to think about the diseases that we treat now as compared to 60 years ago, right? We see a lot more chronic health conditions now. We see a lot more mental health. We see people who are experiencing extreme trauma and adversity in their life. And so, we need different skills to be able to work with these patients effectively, right? So I'm not saying that we dismiss the scientific background or the MCAT score, but let's just put it on equal footing with some of these other qualities, right? And another thing, I think that when we do that, we not only are we able to help our patients be healthier, like I said, it brings more different points of view to our field. So, I think that just to kind of, there's a lot that, these are very, very broad concepts that I'm bringing. And there's definitely a lot we can do within the healthcare field, right? But my intent really isn't to cover that so much today. What I really want is to kind of bring a larger lens. And so just to kind of recap what I'm saying, I think there's a lot that we can do to advance health equity, starting with, promoting social determinants of health early on, having a more diverse workforce, and really getting physicians to think of themselves as advocates. But at the end of the day, when all is said and done, we are first and foremost physicians. We are trained to take care of the sick and the suffering. And I would say that this is where most of us are at our best, and most of us, this is where we want to be. This is why we entered medicine, because we enjoy human interaction and building relationships with people. So I would like to propose that we begin to see our daily interactions with our patients as an opportunity to advance health equity for our patients. And so I think that this requires that we apply what I call a health equity lens to each patient interaction. So this really requires that we shift from our traditional biomedical lens to a wider lens, in which we capture a patient's entire environment, including physical environment, social conditions, economic conditions, cultural conditions. Because when we take a step back and we take this all in, what we're doing is we're creating a story of how social conditions shape health. And then we can actually project these stories, right? We can project and share these stories to illustrate how social and systemic inequities lead to suffering and poor health. Okay? So I want to emphasize that that the stories that we collect as physicians are unique to us. And they depend on our intimate relationship that we have with our patients. But yet they are a powerful tool to advance health equity because our stories put a face on human suffering. And when we see human suffering, this can move us to compassion in a way that data and statistics just can't. And I think that when people are moved, can be the first step in shifting attitudes. And I think it's a critical component of meaningful change at a systemic level. I think that if we really are going to fundamentally change systems and policies, there has to be a cultural shift about health. And we as physicians can drive this by projecting our stories. In fact, one of the things that has happened to me in the last year, anytime I've been asked to speak up or speak out, I have always been asked to share a story. And they want a story of one of my patients. And I understand why. Because our partners have the data, they have the numbers, and they understand, the ins and outs of the policy. But we have that human side. And so I would say that as physicians, let's use these stories to our advantage and see our interactions with our patients as a powerful tool to advance health equity in the patients that we serve. But I want to acknowledge that bringing this health equity lens to our daily work can bring some new challenges to our work, right? Many of us sometimes feel simply we just don't have the time for this kind of listening, right? But what I would say to that was that it's okay if we don't get that story on that first visit, right? And sometimes we don't get a total picture of a patient's circumstances, right? Until we've seen patients for many visits. So really collecting these stories takes time and takes our investment, right? The other thing that I think is really important also to point out is that when we do have this health equity lens, we are seeing more and we are hearing more. And we have to acknowledge that some of the things that we hear and see can be very disturbing. It can trigger responses, right? It can make us feel sometimes despair and overwhelmed. And so I think that if we really want our field to be part of this movement to bring health equity, we need to make sure that we put physician wellness, make that a priority as well, right? Because otherwise what we do is we run the risk of burnout for our patients, or sometimes even worse, we have physicians who go through their own mental health crisis. So I think that we really need to find ways to support physicians, right? And this can be doing things such as decreasing our administrative burden so that we do have more time with our patients, or that we have more time to do the activities that re-energize us and that recharge us, right? So this is going to be an important piece of what we do. But I think the important thing is understanding that we need to find a way to support physicians as we think about going forward with health equity. But on the flip side, I'd like to share with you that for me personally, approaching my work through this lens has actually improved my satisfaction as a physician. And I think that it has the potential to decrease burnout in all of us. Because one of the things I think that I mentioned earlier is that physicians are trained to fix problems. We want to solve problems. We want to make people better, right? And when we don't, sometimes we feel as if we failed. But for me, being able to acknowledge that a patient's health is so much more than what is just happening in that patient room has allowed me to let go of some of that guilt that I used to carry for not being able to fix somebody's problems, right? And this has freed me up to be able to be more present with my patients and to see myself more as more of a partner on their journey to better health, right? Rather than their only solution. So with that said, I do want to begin to wrap up here, but I do want to just highlight some of the takeaway points that I've made so far. So one of the things that I hope that we can remember from today is that social conditions do matter when we're talking about health, right? Racism matters, working conditions matter, safe conditions matter, right? They shape health, and we have to acknowledge these and address them if we are committed to building communities that are resilient, right? In the face of a pandemic like COVID, but just communities in general. If we want our communities to be healthy, we need to begin to acknowledge these social factors and address them. And as physicians, we can be a part of this movement to bring health equity, right? And it could look very different for each and every one of us, right? It depends a lot on where we are emotionally. And it depends on a lot, but there is a lot that we can do. It can be maybe thinking about starting to do some advocacy work, which is what I've been doing in the last year to try to bring better working conditions for farm workers. But it can also be just simply changing the way we approach our patients, right? But regardless of what I do, there's one ask that I do have of everybody here today. And I would like to challenge physicians to lead the charge in changing the narrative of health, right? So that when we think of health, it is not just about healthcare, and it's not just about the choices that we make, but that it's also about the life that we were born into and the conditions that we live in, right? So it's an accumulation of our life circumstances that shape health, including racism, economics, and power. So that when we hear of patients like Luis or communities that are struggling with disparities, that rather than placing blame or looking for fault, that we really try to find ways to take care of them, to have a community that promotes health. For patients like Luis, for Latinos, who many of whom are essential workers, this means really advocating for things such as healthcare for all Latino essential workers. This means sick leave benefits. This means worker protection standards that promote a safe working environment. These are the things that we need. And I think that we can really be a part of pushing these policies. I really think that physicians are really uniquely positioned to carry this narrative, right? Although in the past year there has been some different opinions about physicians, but I would say that for the most part, we are seen as the face of healthcare, and our opinions usually carry great weight and power. And so I would say that let's use this to our advantage. Let's use this platform that we have to change the narrative, like I said. And let's not just share these stories and talk about this with the broader community, but let's share this information with our own healthcare teams and our physician colleagues that may not be as familiar with some of these conditions that I've just discussed, right? I always tell medical students that my specialist colleagues, they might be experts in the kidneys and the heart. And I myself, as a family doctor, might not be up to date on the latest medication for congestive heart failure. But I understand, and we as family physicians understand why our patient isn't following through with the treatment plan. And when we spread this knowledge to our colleagues, we have the power to improve our patients' care, which is also a step towards health equity. I think as physicians that we have a moral responsibility to do this, because as long as we have disparities, it's going to be hard to achieve health equity. And I believe that health equity is a critical component of social, economic, and racial justice, right? When people have access to the things that they need to be healthy, it opens doors of opportunities so that they can then, with their own talent and hard work, they can achieve those dreams. So today, as I wrap up, I really hope that you will feel that you can be a part of this movement. And I want to thank everybody for being here today, for listening. I hope that this has changed your perspective a bit. And please feel free to ask any questions or make any comments. I always love to hear from other people because I learn so much from everybody else. So I want to thank you and switch it over back to Betsy.
Thank you so much for the wonderful talk. We do have one question in the Q&A so far, and I'm hoping we'll get more. I have a couple questions noted down. The first one is, what is your thoughts about whether healthcare is a right? And if so, how do we work around the profit motivation as the primary determinant of healthcare delivery?
Betsy, can you say that again? I'm sorry. Do I think?
Hang on just one sec. I want to make sure that, can you hear me okay now?
Yes, my computer was heating up, so.
Sure. Is healthcare a right? And if so, how do we work around the profit motivation as the primary determinant of healthcare delivery?
Goodness. Great question.
Easy question.
Yes, I do think it's a right. I think it's a fundamental right. Because like I said, it's really the building block to be able to do anything else in life. I agree that it's tough to get around the business model, right? But I hope that if we can really talk about the conditions, right? And how many times conditions are outside of people's control. I hope that we can just begin to change people's attitudes. I think it's a long road, I really do, but this is where I really believe that we as physicians can kind of lead the charge, because and really by just showing people how when you don't have health, it's really hard to be successful, right? And so if we really want to have communities that are thriving economically, you need to have healthy communities to begin with. So for people who are interested more, I guess, in sort of that business model and making money, I guess that's where that I would argue is that, it costs more to have people that aren't healthy. And so it makes sense for us to give people basic rights to begin with, so that they can then do what they need to do, right, to be healthy. So that would be my answer. Obviously, it's a tough question.
Yeah, that wasn't an easy one. So a question that I am wondering, I've actually, one that's a sort of tactical question, and it's related to the topics that you've talked about, but it's one that's on the mind, I think, of some of our members right now. One of the ways that Oregon has responded to the COVID crisis and the way it disparately impacts communities of color is to accelerate the collection of real DE data, the race, ethnicity, language, and disability data, which is an initiative that's been going on for almost a decade, but has been slow to get its footing. I'm wondering if you have thoughts about how physicians can help influence the rollout of that. The early reports that we have are that it's the process for collecting that data, again, specifically right now for COVID patients who are getting COVID tests, is pretty difficult. And I'm wondering if your clinic has good success with that you might speak to a bit, or if you have thoughts about how physicians can participate in lessening the burden of that important data collection while still validating its necessity, if that makes sense.
Yeah. Well, so first of all, I just want to acknowledge that it has been difficult, and I think part of the things that we have to realize is that there's a lot of fear in the community. And so when you are beginning, people are often willing to come forward for service, but when you begin to ask questions, it can seem very threatening. And so I think that's one, especially in communities that have already been kind of under people's radar, right? And so I think that this is what makes it so difficult. And I can tell you from my experience, when we were testing, one of the things that we find is that in order for us to be able to get better conditions for farm workers, we need to be able to prove that they're actually being impacted by COVID-19, right? And that, because right now what we have is Latinos are being impacted, right, across the board. But the reality is, Betsy, is that it's actually more the living and working conditions, because I'm a Latina, but you know, my family hasn't been impacted because I live in a different community and I have a different job. So it is race, but it's a lot socioeconomics. And so what we've been trying to do is we're trying to show that, listen, farm workers are really high risk, but we cannot get farm workers, they'll come forward for testing, but they don't want to tell us what their occupation is, you know? And one of the things that we've been finding that some of these, and I'm not very familiar with these forms, and this is where I need my colleagues to really help me. Some of them don't ask occupation, you know, and so we get race data, right? And we get ethnicity and age, but we don't know where they work. And so this complicates things. But going back to your question, yes, I think part of the challenge that we face is that, you know, even collecting that data can be difficult. And this is why we really need, I think we talked about this before we went on, if we have community health centers or primary care clinics who are often trusted in the community, and maybe we send out our workers, right, or our community health workers or promotores, however you want to call it, maybe people will be more willing to talk. But data is great, but you have to be able to collect it.
Yes, that is the challenge. I think the other question that was just to bring to light a little bit, and we have just a couple more minutes, so please feel free to be brief. The question around how public health and primary care can collaborate better, and what some of the barriers to that collaboration. Yeah, I know Virginia Garcia has been mentioned in numerous conversations that I've had as having a good working relationship in Clark County. But I'm wondering if you could speak to that and sort of how that came about.
Yeah, I think that we really, we were kind of forced into it, because the reality is that community health centers like Virginia Garcia were kind of stepped up into the public health role at the beginning of the pandemic, right? We were offering testing, we were providing the results. And so in some ways there was, unfortunately, public health is an area that has also been impacted by low funding, and they're also is probably struggling, right? They don't have enough people, they don't have enough funds. And so as a result, I think that their response to the pandemic has been a little slow and uncoordinated. And so community health centers like Virginia Garcia, like One Community Health in Hood River, they've stepped up. And so, but we didn't have a working relationship with them before. And so we have developed that. But I think these are connections and partnerships that we need to continue to foster. Because as I mentioned earlier, this is a pandemic that has hit our community hard, but we know that if it's not COVID, there could be something else. There are natural disasters that can happen, you know, forest fires that happen. All of these things impact vulnerable communities more so than non-vulnerable communities, right? And so I think that actually sometimes it's just getting on the phone and meeting with people and talking with people and becoming familiar with each other. And then once we build that connection, continue to try to develop that partnership. So I would love to see more work between public health and community health centers and community-based organizations too. That's what I would love to see. And I think that my hope is that this pandemic has kind of started that work, but there's still a ways to go. Yeah.
That I think is going to be a pretty significant focus for the OFP in the months and years to come. So I want to thank you so much on behalf of the OFP and myself for giving us this incredibly informative talk and sharing your time and your wisdom with us. I know that you're extraordinarily busy, as everybody in healthcare is these days, and we're really grateful. We're sorry that we couldn't have you in April, but boy, the context is even more critical now. So thank you so much.
Thank you so much, Betsy. Thanks to everybody. Have a great day.
Thanks, everybody.